Welcome to EuroPCR 2025. My name's Elliot Smith from Barts Heart Centre in London, and I'm joined for this discussion on CTO intervention by Thomas Hovasse from Massey and Roberto Garbo from Turin in Italy, both good friends and highly expert CTO operators. This discussion is going to be about how we successfully approach CTO interventions. So Thomas, CTO can be somewhat overwhelming and potentially complex. What do you think are the very first steps to get started on the road to approaching any given CTO case?
Thank you, Elliot. So I think my first advice for a new CTO operator would be to do a very good and specific angio, which is not the same as a standard angio. I will make some more view. I want to really see the CTO, the beginning of the CTO, which the proximal cap, the end of the CTO, the distal cap. I want to know the length of the CTO. I want to see if there is calcification. I want to see all the collateral, septal or epicardial collateral. And for that, I will need more view. Maybe I will need to go in 15 images per second and really want to have a very good angio. And most of all, after all that, I will stop. I will not start my CTO right away the angio. I need to think, to see again the image and stop the angio and discuss the CTO.
So we've already established that there are some key anatomical features that we absolutely have to see.
Yeah.
And you've named a few of them. We've got the proximal cap, the nature of the distal landing zone, whether it's close to a bifurcation or not, the lesion length and the presence or absence of interventional collaterals.
Yeah.
And then we've also got issues in and around calcification.
Sure.
You're saying higher frame rates. Is there anything else about the way that the angiographer should be taking those images to ensure that we can see everything in one go?
Yeah, sure. I think a few more advice is to avoid panning, because if you move the image during the acquisition, you will see nothing or very badly the collaterals. You have to make very long injection to see the feeling of the collateral until the end. And if the injections are not so good, don't hesitate to take for the angio a guiding catheter, 5 French or 6 French, to really feel the arteries the best you can, and to have the more information you can need.
Now, of course, when we do the initial diagnostic angiogram, we don't have dual catheter angiography. We don't have two catheters at the same time. That's not until we approach the intervention. But what you're saying is you can get most of that information if you just make sure the setup is right.
Yeah.
So, okay, we've spoken about what these anatomical features are. Why are those anatomical features so important? How does that anatomy translate to the way, Roberto, that we're going to approach the CTO?
Exactly. So after the anatomical evaluation, we can consider many different strategies. So strategy are depending on your experience. The first strategy, of course, is antegrade, but sometimes it's not possible. So evaluating the proximal cap, we can decide if we can go on with an antegrade puncture or we need something more like IVUS to evaluate the proximal cap location and plaque morphology. And then if we are not able or we fail antegrade, we need to be able to switch fast with the retrograde approach. So my suggestion is that we need to be able enough to change strategy, to be able to be flexible, because this kind of procedure can be done successfully if we are able to change and don't stuck in a failure mode for a long time.
So we've established that there's a number of different interventional strategies and techniques that a CTO operator is going to need, starting with an antegrade approach, but then potentially escalating to retrograde approaches. But within both of those, there are other techniques as well. Can you tell us a little bit about parallel wiring, dissection techniques, both antegrade and retrograde?
Yeah, Elliot. So if we talk about antegrade approach, we start with a single antegrade wire escalation, but if we fail, we go subintimal. We can use dual lumen for parallel wire technique, using a second wire as a stiffer wire, try to stay intraplaque. Then if we fail, or we have no good retrograde option, we need to consider the ADR, so antegrade dissection and re-entry. So we go beyond the distal cap and we try to re-enter. We have a device-based strategy for re-entry. We had even IVUS-guided strategy for re-entry from the subintimal space. So this is all the antegrade option. Then if we think about retrograde option, we need to carefully evaluate the collateral, because we can start with a septal or saphenous vein graft as a not so expert operator. Then if we increase your experience, your skill, you can go on even with the complex epicardial collateral. So, but these require a good training, require experience, and so it's very important to have a proctor together with you if you want to start this journey that we can consider as a pyramid. So CTO are probably the most complex procedure in interventional cardiology, but we can achieve very high success rate if we go on this journey with a step-by-step approach.
So we've established that we've got a range of different interventional strategies. We've spoken a little about how the particular anatomy might drive any particular strategy. But there's a training need along the way that not everyone might be expected to know all of those strategies at the beginning, and that there may be some sort of journey through less complex, through more complex CTOs. Just before I leave you, Roberto, what are the key factors that drive you antegrade, and what's the key factors, just in a couple of words, that drive you retrograde, just to give the audience a flavor of bringing it back to the anatomy that Thomas told us about?
Yeah, this is really important. So when I'm approaching a CTO, I'm looking of all the aspects. Even if it's a quite simple CTO, like with tapered cap, and I think that I will go antegrade, I carefully evaluate all the possibilities. So even there are some retrograde option, because I need to be, in my mind, I have to be clear that I have a different option. So for antegrade, if I have a tapered cap, I would start always with antegrade approach. For starting retrograde, if you have ostial RCA occlusion, we need to start retrograde, but we have some different situation like proximal cap ambiguity, in which if we want to start antegrade, we need to evaluate the proximal cap. So imaging is essential. So if we have a side branch, we put the IVUS and we evaluate the proximal cap. Or we need to go retrograde to knuckle down and then go up to the proximal cap, or try to use the technique of the move the cap. Move the cap technique is something that we overcome the proximal cap ambiguity, going subintimal, but then we need some technique to re-enter in the vessel. So we need retrograde or we need ADR.
So it just shows you that you hear the proximal cap come up over and over again, and this idea that a very clear proximal cap with the taper is going to drive you antegrade. A very ambiguous, difficult proximal cap where you don't know where the vessel is beyond may require some specialist skills to resolve that ambiguity and keep antegrade, or it's going to drive you retrograde, particularly if you've got very good collaterals.
Exactly.
So we're building up an idea that we've got these antegrade skill sets, retrograde skill sets, we've set up with the anatomy. So now we're in the procedure with dual catheter angiography, Thomas, and what tools does the emerging operator, indeed what tools does the expert operator have to have available to them in order to approach these sorts of cases?
Yeah, I think we all need, as doing CTO, a minimal toolbox. My first recommendation would have to be a 7 French guiding catheter, because for this kind of operation, the more the backup support will have, the better, the easier to perform. And then for sure, I will not perform a CTO with my workhorse wire, so I need some wire, soft wire, to travel into micro channel into the vessel. I will need a stiffer wire to manage more stiffer CTO and to cross CTO. For sure, one of the most important things is to work with microcatheter, because you will have a control of the wire which is a lot more easier and improved, and you can exchange wire. If one wire is not fitting, is not going well, you can change it on the microcatheter very easily. So a few wires, big guiding, microcat, and then if you're going to retrograde, you will need longer microcatheter, you will need dedicated wire for the retrograde, and then we will have a lot of device possible and usable for our CTOs.
So we've got this minimal tool set that you need, really the appropriate size guiding catheters.
Yeah.
You're going to need a range of additional wires. We're used to, as PCI operators, using 1, 2, or 3 wires,
yeah.
and suddenly you've got this overwhelming array of different engineered wires, up to 50 on the market, that we have to choose. And the key is to understand that each of those wires is engineered for a specific task, a specific point. So there might be wires that you would use at the proximal cap, whereas they're not the wires that you would use to go through a collateral.
Yeah.
And each of those wires has to be supported by microcatheter technologies. From your point of view, how easy or difficult is it to start to integrate those tools into your clinical practice? And can you give a word as to what the key minimal tool set would be for microcatheter and wire? And that's a difficult question, but just in terms of types of technology.
At least 1 micro, for sure, we talk about it. Maybe 1 soft wire, then stiffer wire that I can direct or redirect within the CTO, a polymeric wire to navigate in the architecture of the vessel. And my advice is to start with maybe 3, 4, max 5 wires to really learn to deal with them, to master them, and then increase your toolbox. But not start with 12 wires, because you will use them 1, twice, maybe 3 times, and it will not be helpful, and you will not progress as if you have less tools, but you will know them better.
Now, if we were to just stop the discussion here, and people weren't listening any longer, they might say, right, I'm going to go off, I'm going to buy myself my 5 wires, my 2 microcatheters, my dual catheter angiography, I'm going to do a great angiogram, I'm ready to go, I can start my CTO program. Roberto, there's a bit more to it than that. How do you approach it in terms of learning the appropriate skill sets that match these technologies, that enable you to use these technologies? How do you actually build the skills within CTO?
Yeah, I started CTO program 20 years ago, and now everything changed. So I think that there are 3 main points we need to consider. The first one, that if an operator, a young operator, wants to start this journey, that is a beautiful journey, he needs to study a lot. So we have a lot of books, and you need to understand, to study, to read all the technique and strategy. This is really important. The second point, there are many live courses, live congress, in which you can see the master operator working in a live case. You can understand how they are flexible in their strategy in order to achieve the success rate in the fastest way and the best approach. And the third point is proctoring. So you need to have an expert operator with you that can help you, can make you feel comfortable to go on your capacity and go on with the different strategy, because you know that he can help you in some situations. So at the end, after these 3 points, then you can start. You need to go by yourself. You need to go on with this kind of CTO procedure as a first operator.
There'll be nuances and differences between different operators and different trainees, but broadly speaking, in that hierarchy that we spoke about, from antegrade wiring, moving all the way up to the most complex types of CTO that need all techniques, what sort of order would you expect people to learn the key techniques in, starting with simple antegrade wiring? What's the next step and the next step and the next step?
Yes, from antegrade point of view, single antegrade wiring, and then I think it's really, really important to understand how to use imaging in the modern approach to CTO PCI, because imaging is essential in complex PCI, but in CTO, even for technical reason, as we discussed before, so evaluating proximal cap is really, really important, but you need to understand imaging to be able to use during the procedure. After that, if you're able to do this kind of antegrade and you are able to start to understand how to make the ADR, so dissection and re-entry, then we go with the retrograde approach. Retrograde approach, you start with quite easy septal, and then, because after the septal, then you need to make the connection, and it's not easy. But once you are on the retrograde part of the distal vessel, this is the first point of your procedure. Then we can go on with more complex collateral, like epicardial connection.
So we're saying we start with antegrade wiring. We may then move to either learning to integrate some dissection techniques antegradely, or we could move to simple retrogrades through septals. Then we start to learn how it's really about connecting up spaces, whether you're working antegradely or retrogradely, to facilitate success.
In this situation, Elliot, I can tell you that you know exactly that the key point of retrograde is to make the connection between two spaces. So it's not about to stay intraplaque or extraplaque, but both wires need to be in the same space. In that situation, IVUS, again, can be really useful to understand where you are.
And I suppose success is an open artery, Thomas, with outflow into all main branches. But just tell me a little bit about failure and where those points are of over pushing a case. Is it okay to fail?
Yeah, sure. The artery is already occluded, so you have not the same pressure than when you deal with a STEMI, for example. So my main concern would be not to harm the vessel or to have a complication. So stay safe, patient first, always. But we know that CTOs, difficult CTOs, can be very complex. The success rate is very good now in a large center with good experience, above 90%, but it's not 100%. You have to tell the patient, you not succeed. Maybe we can retry it, because generally when performing a CTO, you are with a dual injection, with all you've done, you understood things that can help for a future success. But failing is not, even if we want to succeed all the time, failing is not a big deal if there is no complication.
Yeah, so failure without complication is far better than a partial success with a big complication.
Yeah, sure.
That's no good at all. And you brought up that great point that we're working in a time-limited environment and in a X-ray and contrast-limited environment, where if the first and the second and the third strategies are not successful, you can stop, pause, and rethink the entire Hovasse strategy, or bring back and go another time.
And then I think that on that topic, we teach to the young operator that failure often is a way to improve your skill. So if you fail with a good strategy, using the good material, good device, good guide wire, good strategy, then you can learn a lot from a failure. And it's much better than sometimes have a success by chance that you don't know why your success is good to open the artery. But for your training, failure is a way to understand the next procedure, how to get better. So I think that this is a part of the process.
Yeah, absolutely. And that's a life lesson in itself, which is failure isn't the opposite of success, it's an integral part of it. So I think we can bring all of those discussion points together. I want to thank you both for joining me. And what we've summarized here is that just starting with the angiogram, anatomy dictates your interventional strategy. And so we really have to make sure that we get the right angiographic images right at the start. And then, Roberto, you've told us that you need all of the interventional strategies in order to be able to switch from one to the other, and we need to learn to fail fast and switch to a better strategy during the case or come back on another occasion. But Thomas, you've told us that although you need certain tools and skill sets, the bottom line is that these tools aren't going to enable you. You're going to need training, and that starts with courses like these, dedicated courses on CTO, proctoring, and then ultimately getting out there and doing the cases. So I want to thank you all for coming along today. I hope we all have a great meeting here at PCR 2025.